Welcome to Legacy Sips and Tips podcast with your geeky host, Lindsay Wheeler, where we talk about everything from death, preparing for your future through estate planning, life, the occasional breakup, entrepreneurship, general nerdery, and of course travel, snowboard, and always wine. This is part 3 of our episode with Molly Wilder. I know we're talking a lot here, but this is super riveting information that people need to know. The most riveting. And so happy she is here with us, and you guys get to experience part 3.
Yep, still here. We'll come back again. Doesn't mean, and that's the other piece too, DNR, do not resuscitate, does not mean do not treat. So we can get patients that come in with DNRs all the time, but they're DNRs for different reasons, maybe. And what they're in for to be treated may not have anything to do with any of this stuff. So we're still going to treat them to the full capacity. And that's the hard part, is that, like, again, on paper, we see patients, we look at their age, we look at what they're coming in with, and we look at their resuscitation status. Yeah. If they're listed as a DNR, I mean, it kind of gears our brain towards one thing, but it doesn't mean we're not going to give you antibiotics, we're not going to give you like fluids. Well, we might even put you up on a pressor to keep your blood pressure up if it's just a little on the low side, but that's not what we're treating you for.
Right. You're not going to have people come in and be like, oh, you got DNR, YOLO, we're out.
Exactly.
Peace out.
Like,
no,
why are we
worry.
admitting this patient? We don't do that. Yeah. And that's the hard part too, that some people don't necessarily understand. And hospice goes with that too. Like, we'll get hospice patients that come in and we're like, oh, well, they're hospice patients. Why are they seeking care? Because what they are on hospice for is not what they need care for in this moment.
Yeah.
And so
they have a bladder infection or something. Yeah. Something that's completely not related.
That's kind of a stigma that I would say the non-medical person would think when they hear DNR, is that they automatically assume that you're not going to do anything for that patient. And that's definitely not true. We still will treat the patient to the degree, and again, as what you want. If it gets to the point with what we're treating you for, you in the meantime, your heart stops beating or you stop breathing or anything along those lines, do you want us to do X, Y, Z? You know, if you need to be on tube feed for a day or two, even though you've listed on your pulse that you don't want any artificial feeding of any kind. If I tell you it's only, 2 days worth just to get your bowels up and running or something along those lines, of course we can do that. It's not, we're keeping you on the tube feed for the rest of your life.
Indefinitely, because you're unable to do it for yourself.
Yes, yeah. Like it can be, and that's where it was a little frustrating for me when my husband did some of that stuff, because that's what he listed, was like, oh, well, if it's only for a little while, yes, do all the things. And I'm just sitting there like, have I taught you nothing?
Right. Yeah. Have you not listened to me? Oh, wait, you're my husband. No, you haven't listened to me.
Right. This whole time. Yeah. Yes. Selective hearing. But again, his view of healthcare is different from mine because he's not exposed to it as much as I am. But then you look at my sister, who trusts that both my brother and myself and my sister-in-law, who are all in the healthcare field, are going to do right by her and help her make these decisions because she's not a healthking professional.
Right. So, that's why I have you, and then Bridget, who's an anesthesiologist up in Washington, can get down here with the really good drugs. Yeah. You gotta pick the people who are going to advocate for you. If I put my boyfriend on there, or some of my other more gentle friends, if you will, they're not. There's no way they're going to make those decisions, and nor would I want them to. Yeah. You know what I mean?
You put them in a tough decision, in a spot where they're like, shit, am I doing right by you? Right. Do I really know you well enough to make that decision? And it's stressful for them. Yeah. And again, that grief and everything else comes running in, where they're just like, shit, I don't know if I did that.
And this is why it's good to have conversations. I don't think there's a single friend of mine who does not know what I want. Like, we kind of flippant about it, we joke about it, but I literally don't think there's a single person that I know who does not know what I want. Same. So you guys can Voltron together, and if somebody's like, she would never want that, there's 17 other people who absolutely know what I want. Yeah. You know what I mean? Because my mother, I'm sure my mother, as most mothers would be like, oh, no, you know, but all of you would be like, yes. Yeah. You know, so that's why it's important to have these discussions with your family, with your friends, with your advocates, with your people, with your partners, whatever it is, so they all know, like, there's no question, if you will.
Yeah. And I will say, like, when I talk to people that aren't medically based, they're enthralled by these types of conversations, because they're that they're just like, you deal with this every day. And I'm sure there's nurses out there that deal with it more than I do. Sure. Like the people who work in oncology or those types of places, like, God bless you, because I wasn't built for that.
No.
But, and I'm happy that there are people that do, right? Yeah. But they're completely enthralled in the fact that, again, because it's not a conversation that you have regularly, but they're just like, when you give them examples, like we've done today, to say, like, this is when this worked and it was great, and this is when it didn't work and it was a shit show, you know, they're like, oh my gosh, wow. Okay, I learned something today.
Yeah.
And you're to me, it's like an average day of just sharing what I do every day. But for other people, it can be kind of eye-opening to them to realize, like, oh my gosh, like, one, that's what you actually have to do. When we start talking about patients and how they can be dicks and be very rude to staff and things like that, like, that's a whole nother conversation, which most of my teacher friends are like, oh yeah, children are the same.
Right.
Yeah. Right. Like they're aggressive. They're abusive. They're verbally abusive. They throw things at you. I'm like, patients are the same way. A lot of that has to do with their vulnerability and their lack of control. They lose all of that when they come into the hospital. So it's really up to us.
And they don't feel good, and they're not you know, like even when I was there, I yelled at the doctor for one because he was kind of a dick, and the nurses snickered at that because I was like, man, bro, you're kind of a dick. And we're like, yeah. And the nurses were all, and one had to like leave the room because she was cracking up, and they're like, see, you know, or like, you know, I yelled
come in and like silently high five you, and they're like, we've been waiting for somebody to say that.
Yeah. And then, you know, like they had to draw my blood every hour, and that hurts, you know, and you're waking me up, and I'm like, why are you doing this?
Yeah, like, lack of sleep is a huge one. When you get people that are just exhausted, they're gonna snap at you. I would snap at you.
And the doctor or the nurse at that point was very accommodating for my snappiness, and was just like, we have to do it every hour. We need to get your baselines on things. And I said, okay, I'm logical. So if you tell me why you're poking me every hour, waking me up, okay, I'm gonna be a little bit more accommodating. I know you're doing your job. It's not your fault. You know what I mean? Yeah. But lack of sleep, you're in pain, you're in an uncomfortable situation. The hospital rooms are scary. You know, all of it's just
you don't have family next to you,
like 24/7.
And I don't know. I can't speak for other hospitals in the area, but our hospital in particular, like we have specified visitation time, and we don't typically, since COVID, we don't typically let people stay the night. And you get some Karens out there that are just like, man, I can't stay the night, and I'm like, I don't want you here.
Right. Yeah.
You know, and
you're also in my way.
Yeah. And there are times when it comes to end of life, we accommodate for things like that where it's like, I can't guarantee when this patient's going to pass. I want you here. So if you're willing to stay and be at the patient's side, I'm happy to meet those needs. End of life always is a conversation. And again, ethics is always a huge piece to that, where it's just like, again, if that was my family member, what would I expect from these nurses is typically how I try and run things too. But then, you know, same sort of deal. If I was in this patient's shoes or stuck in that bed, how would I be responding with or without the knowledge that I have? And so I can go from zero to bitch real quick, but it's really about the communication. Like you said, if you tell me what's going on and you talk to me about stuff, great.
And that's what's hard. Like, I don't think people understand that you're more than likely going to die alone. Yeah. You're going to die in this kind of situation. You're going to have people that you're not your close family or whatever. Like my 92-year-old, she passed at like 3:00 in the morning. I wasn't able to be there, and that kind of eats at me a little bit, you know what I mean? But hopefully she was morphined out enough that, you know, that was great. Yeah. But you're probably going to die alone, and that's scary for people. But it is a natural process, and, you know, it is the way it is, and making sure that these things are in place so maybe you can have a little bit more control over that. You know, I would have loved to have been there and blasted opera for her the entire time as she passed. You know what I mean? Like, she would have loved that, you know? It's what's important about having your death plan in place, having these things in place for people to know. Yeah.
And just getting over the stigma of it being a huge issue to talk about. It's just like, I mean, even I was in a pretty horrific car accident and am happy to be on this side of the planet. But
we call it the salad incident because she had groceries in the car and the salad got shoved in the window of the car of the truck. So
it was probably the only thing that remained intact in that vehicle. The salad. Thank God they built cars the way they built cars back then. But that was a huge open thing, an awakening thing. My husband didn't like to talk about it. He did not like to be in the room when I talked about how close I was from not being on this earth. And one of my very best friends, same. Like, she does not like to hear me talk about how close I was to dying. And she's just like, I don't know why you keep bringing that up. And I'm like, it's important to talk about that.
Well, and you need to process too what happened to you. You know what I mean? These are important things.
And I'm like, I'm not doing it for attention. I'm doing it just to make it aware that anyone can go at any time. Right. I mean, you mentioned your friend's son who who passed in the motor vehicle accident and things like that. Stuff happens all the time.
For myself, I'm snowboarding one day and then I'm in the ICU bleeding out the next, like it's just, it's crazy.
But this sort of stuff, the things that you guys set up for clients can help for expected and unexpected.
Yeah.
And the unexpected is always the hardest because then you're just like, oh shit. For example, we just had a gal who, just speculating, seemed like she was a mail order bride from the Philippines. And she was married to a white gentleman here in town, and he was dying. And her biggest concern was what was going to happen to her when he dies.
Oh.
And she kept asking us, does she have to go back to the Philippines? And I'm like, I don't know, but it's like, it's stuff like that she had no idea whether or not he had something set up that said that she could stay here. She was legally married. Yeah, she was legally married to him, but she was saying, she's just like, I'm not from here. I don't know what this looks like. Do I have to go back? Can I stay here? His family wanted nothing to do with her, unfortunately, and so she was very concerned about, what does this look like for me? So she was holding on to him as much as she could,
naturally,
because she was scared of what life without him was going to look like, and I don't know their living situation. So for me, as an advocate, to try and help ease her concerns at the same time as taking care of her husband who's actively dying, it was a lot of stress on me because I'm like, I want to keep her comfortable and I don't want her crying and making. I don't want to say it's the wrong decision, but making decisions that are strictly for her benefit versus his comfort.
Right. When they should have had the conversation, had it set up to where you don't have to go, you don't have to go anywhere. This is your house. This is your home.
Yeah,
we have it set up.
Paid
you can
for.
Stay
Money's here.
Yeah.
This is who you need to talk to after I die. This is my lawyer. That sort of thing. They will help.
That legacy vault where she could just log in and find all that information. Hint, hint, everyone.
What does this look like for her? Is everything going to her? Is nothing going to her? So, that sort of thing. And she's asking me, and I'm like,
especially if you have blended families.
Oh, yeah.
That happens a lot too.
Yeah.
Children from prior marriages getting cut out completely, and new evil stepmother, which I am one. Taking all that away from those children that were supposed to get that, and now they're not because they didn't have anything in place, or they're their spouse.
Those turn into the Jerry Springer episodes I was talking about, where they're all at the bedside just ready to rip each other's throats out, and you're like, excuse me, I need to get in here and do my job.
Right.
It's not my job to referee these types of situations where these family members are fighting over who's making the decision and who's going to benefit from it. I've seen people keep people alive until they, in the background, can finagle things out of homes, sell things off, figure out where the money's at. And at the meantime, they're saying, oh, no, just keep him going. And I'm like, he's only going to stay on this planet for another day or two.
Because they have power of attorney, and power of attorney only lives when they live. When they die with you. So that's why they're trying to keep him alive, because that power of attorney is still active, so they can do shady things sometimes. So that's why it's very important to put people on your power of attorney who you trust, know, it's going to do your advocacy for you.
Yeah, not going to steal shit and sell your house off and all of the things. I've seen that.
I've seen it too. I've seen people where I've been in the hospital helping them get their stuff in order because they're still lucid and cognizant and able to do that. And in the background, literally they're having to go immediately have the locks changed because somebody's coming in from the woodworks knowing this person's going to pass and literally emptying the house. Or if there's one client we had where it was a blended family, the ex-wife they were not savory people. The children were kind of drug addicts, not really good. And their father, unfortunately, OD'd on bad cocaine, was laced with fentanyl. He was partying with his older daughter. This is like a crazy situation. This is so Jerry Springer.
Yeah. I'm telling you, it happens.
Yeah, the children, knowing he was in the hospital, was in a coma because they're like, whether we're going to pull him or not, took his keys, went to the house with a U-Haul. They went and rented a U-Haul right away or got trucks with their friends and literally emptied the house while their father was actively dying
in the hospital.
That's this so stuff shitty. Happens.
Yeah.
So that's why it's important to have this stuff in place, because if they did, they could say, nope, that was not what was supposed to happen. They would have had the authority to lock that house out, make sure that those assets were protected where he wanted them to go, and then, not have to worry about that. And there's many things missing. Yeah. And I'm sure at the pawn shop right now.
Yeah.
Just sad.
Yeah. And trying to regulate family members that come into the bedside. Again, HIPAA is always a huge piece for us. And especially when patients are actively dying, or if there's a reason why they're there, and drugs or alcohol, that sort of thing, if people didn't know about that. And it does crack me up, the number of people who think that they're privy to information. Right. And I'm like, what's your relationship with this patient? And they're like, oh, we're neighbors. And I'm like,
yeah, wait, what?
I'm like, I mean, I moved out to the sticks, so I don't have neighbors. So if somebody came in and they're like, we're neighbors, fuck
people
off.
Would be like, yeah.
Do not give that person any information. But, and they want to know all of the things. I've had people try and take wedding rings off of patients when they're sedated and on vents and not doing great and whatnot. And, you know, and we see all this. And now I move from, you know, being a nurse to being Jerry Springer's bouncer. What the hell's that guy's name?
I don't even know.
Oh, he has his own show now.
Yeah. Oh, yeah.
Wilkins or something like that. Anyway, but you know, now I have to
You're
step
that guy.
in.
Yeah.
And fortunate for me, well, I shouldn't say fortunate for me, fortunate for the other staff members who are those Care Bear type people, and I am not, I have no problem telling people to get the fuck out.
Right.
And so, and call security and whatnot. And so now I have to fucking, you know, wrestle these people out of the things that they want to do because they're horrible people.
Yeah.
And like you said, when that happens and the patient can't do anything about it because
And then and think about that. You're trying to pass peacefully. You're hoping your family's there. And you are probably aware, even though you might not be, you know, conscious, you're still probably aware that your family members are biting.
Psychologically, they say that you can hear.
Yeah.
Like that the hearing is the last sense to go. And so I always tell people, like, you can talk to them. They can hear you, right? And that might be beneficial. But yeah, if you're fighting at the bedside, I'm like, I ain't got time for that.
We had one, and this is why people come to me, that they become triggered to do this for themselves because they now have experienced themselves. And they had this gentleman came to me with his wife, and it was his wife's mother who was passing, and she had siblings, and they had a stepdaughter that the mother had raised, like, from basically since she was like one. Since she was little. He's like, it was beautiful. Everyone was in the hospital room, like you said, the most perfect situation. They're kumbaya-ing, mom's passing, we love you, you've been so great. And as soon as she codes, stepdaughter gets up and literally takes the diamond earrings off of her ears. Stop. She's not even cold. Yeah, fist fighting, of course, ensued.
Wow.
You know, security has to be called. Like, you know what I mean? Like, it's these things happen. And she was like, but mother said I could have these. But did she?
You're like, well, at least,
the estate plan's very important. That you would put diamond earrings to stepdaughter, which may have been fine, and she could have went, look, this is what mom wanted. But the fact that she did that, and the other siblings were like, absolutely not, like literally fist fighting in the hospital room. Yeah. As mom is passing, probably maybe has coded, but it's maybe still kicking around in there.
Sure.
And now is being literally grave robbed, you know, by family members.
It's crazy. Yeah. I mean, like, death and greed is like...
Yeah, I always say the best in people come out when people die. Yes. Like, it's crazy. Like, people get so weird. Yeah. Even in my situation with my 92-year-old, you know, I, of course, was not related to her. And her son, we had a TPO against him. Hopefully, you know, that is no longer a situation we have to deal with. I don't want to say anything uncouth about that, of what my wishes would be.
Yeah. But we know something
about a ditch and things, you know.
I can make it happen.
Yeah. And the estranged daughter-in-law was asking about beneficiary designations on her life insurance. She's not even dead yet. Like, what is wrong with people? Yeah. Like, not, oh my gosh, I want to come see her. She was so wonderful in my life. She was like a mother to me. No, oh, we got to get the death certificate so we can get that life insurance, you know, get that rolling. You're like, oh my God, she's not even dead. What is wrong with you? You know, so yeah, people are awful about this. This is why it's very important to have the plan in place.
Yeah, and like you said, making sure that the people that you are putting into those positions, unlike some of our new cabinet members, can actually do the job that you ask them to do, and that they're trustworthy, and that you are hopeful that they will follow out your wishes.
Yeah, that's why it's super important. This is ridiculous.
She loves it.
She does. Her husband is also a car enthusiast and a cat dad.
So. I almost wore my shirt that said, I love beer and cats.
Yeah. Yeah. You're so silly. She likes to be on your shoulder. That's why I thought it was funny.
I know, she's just like, hi. There's got to be a million nurses out there that have experiences very similar, if not worse than that. I mean, it's stuff that we see chronically, and it's unfortunately always going to be an issue, but I don't...
And people don't understand, like, actually what the dying process looks like. What is that? What physically happens to your body? What decisions do you guys make as medical professionals? How can we help you make those decisions and advocate for patient care? You know,
again, it's not something that family members ever think about, but we do, and especially me moving into where I would have to be aware of, can the patients that I'm taking care of even afford some of the things that I would be prescribing for them? In the hospital, most often it's all covered by, you know, the hospital stay, or if they've got insurance, Medicare, all of those things. But I mean, even just like putting an NG tube in, putting a Foley catheter in, all these things are uncomfortable for the patient to endure. Surgery, all of those things. CPR is a really big one. Being intubated is a really big one. Is the patient going to be able to come off of the ventilator once we put them on the ventilator? That was a big thing that COVID, I don't know if you remember, that was a huge piece where they were saying if you have COVID and you get put on a ventilator, the likelihood that you'd come off of that ventilator was very poor. So people, every time they associate, when we say they're on a ventilator, they're like, oh my God, that's like a death sentence. And I'm like, it's not though.
That was just a circumstance that we were experiencing at that time. Yeah.
And so, but yeah, I mean, death is not great. And sitting there watching someone get closer and closer, again, with just the way that they look physically, they're not mentally with it. They, you know, their eyes might be rolled back in their head. They're breathing
they
at
usually lose a lot of weight,
breaths per minute. They have fevers. They're sweating. They have no color in their face. They're not able to talk to you. They lose that pain sensation, and it's not something, like I said, I would not want to sit there and watch my father, you know, go through that if he didn't have to, if there was another way to make him more comfortable, knowing that there's nothing else that can be done.
Right.
And so, or knowing that he wouldn't want to continue to live that way. So why continue to make him live that way? But yeah, the dying process in and of itself is horrific. And it's the ones that go quick are blessings, obviously, and the ones that kind of take forever. Those are typically like your cancer patients and things like that. That it's just prolonged, and it's like they're going to have good days, and it's going to give you hope, and then they're going to have bad days, and you're like, you want to point the blame. Like we get patients that do that they're just like, well, what happened? Their family members are like, what happened? I'm like, they're not well, you know, like they're sick. And they're like, well, they were good yesterday. I'm like, yeah, that was yesterday.
Right.
And I'm like, but they have a fever today. We've had to add an extra medication to help with their blood pressure. Their bodies can only do so much. Right. And especially with our elderly, we see that. And so having somebody to explain it, though, and I have had family members mention, you know, like, thank you for taking the time to explain to me what this looks like. Like, I'll draw pictures for family members. Yeah. We have whiteboards in the room. I'll draw pictures, in particular with the gentleman who had the necrotic bowel, like drew pictures of where they put the pieces back together and how that leaks out and where it goes and things like that. And so when she kind of saw that a little bit, she was like, oh, okay, that makes sense. Yeah. And so, and then she'd look at the patient and be like, so that's this? And I'm like, that's this. And she's like, oh, okay, that makes sense. So, and that's one thing that I think overall in medical gets missed, right? Because we're in to do a job, and sometimes our job isn't to talk to family.
That even happened with me. Like, I mean, I am the patient. I am unconscious. Things are happening to me. I don't really, frankly, know what's going on. I just know I wake up from surgery and I'm like, oh my God, my arm doesn't work. And why does my leg hurt? I hurt my arm. Yeah. Well, they had to take the vein from my leg to patch my artery. Bless my doctor, who is an amazing doctor. I have a functional hand and arm because of him and my orthopedic. But he literally went and got his textbook to show me what he actually did, you know, because I don't know. You guys all know, or my family knows, or whoever's known, because you're conscious and awake and what are we doing to her or whatever. But sometimes as a patient, you don't even know what they're doing for you. And so having that time that he took that time, literally went and got his textbook and showed me how I literally blew my arm out textbook style, which was hilarious. He goes, oh, you're in the book because you did it just perfectly, how, you know, and I was like, oh, that's fun. And he's drawing in his textbook, showing me like, this is what we did, and this is why your leg hurts, because we took the vein from there, and we patched your brachial artery, and we took your saphenous vein. You know, it's like cool things I think is missed, and people, when you don't understand or you have that unknown, it becomes very frightening and scary.
Yeah.
You know what I mean?
And using medical terminology and jargon is one thing that I think most doctors lack, which is one of the things that nurses, in particular nurse practitioners that move into that, we're used to having to explain things a little bit more because we have more time also.
Right.
Well, you know, docs have a million things to do. I'm not discrediting doctors by any means, but you know, we take the time to explain that to them. Yeah, they're in. They do whatever they need to do and then they leave. And then it's our job to be that kind of go-between. And sometimes that means having to explain stuff. And so taking the time to kind of, I don't want to say like dumb down, but sometimes you kind of have to read a person's health literacy, like whether or not they're able to comprehend what's actually going on with them. Yeah. And so drawing pictures, using analogies that you think they'd understand, using just regular terminology rather than saying your brachial artery. I might actually show you like this artery right here, and arteries like, you know,
the highway
blood,
of your stuff.
And have to do all of those things. And sometimes that's all it takes for them to understand, and they're like, oh, okay, that makes perfect sense.
Right.
So,
and it gives them a sense of ease and understanding, and they're not feeling like they're being talked down. And we do that in the law all the time because we have legalese, and it's gatekeep from people, and it's just like, no, this just means this. Yeah. Is all it is. And we got some fancy Latin term for it because we want to feel special and important that we paid that much to go to law school. And really, it just means this.
It just means,
you know?
This. Yes.
And for me, like having you guys and having my friends go through medical school when I was going through law school and stuff, and then also, you know, I have a lot of people where you're like, oh, are you in the medical field? And I'm like, no, I did criminal work, so I know how to make a body not work because I did a lot of autopsy reports that I read and going through trials and understanding that. And so I have a different type of knowledge set with that. But, you know, having just that knowledge for people and taking the time to talk with them so they do have an understanding of what's going on with their loved ones makes it less scary for them. And nice.
And we have the luxury in the unit that I work in right now that we typically, and again, every nurse brings something different to the table. Like I said, I can be that person that you have a patient that's being a dick. Hi. Yeah. I will outdick you. Yeah. And so good luck trying to argue or the door's over there type of deal. Like I bring that piece. We have other nurses, thank God, are, you know, your happy-go-lucky Care Bears that will take family members aside and discuss that with them.
And hold their hand.
And hold their hand and do that. And so collaboratively as a team, and I think you'll find this everywhere you go, collaboratively as a team, we work to kind of focus like, okay, like, again, Molly, this is your patient. You focus on the patient. Let me take care of the family. Yeah. That sort of thing. And so,
or they're like, Molly, we need a room. Yeah. Come forth.
Yes. Yeah. Overall, you know, you're meeting the needs of everybody all at the same time. But communication is massive.
Yeah. And then, like I said, like everybody, you know, who's in this profession gets into it to help people, you know, like, I don't care where you're from, what you do. If you're in the medical field and you're doing these things, or even sometimes in the law field, like you're there to serve people. You're serving, you know what I mean? And you're helping people, and those personalities come out. You and I have a similar personality of like, we're getting stuff done. Yes. And that's where it was great with my 92-year-old, where she really deferred to me. And even when she was starting to lose it, she knew that I was the business handler.
Yeah, that you were going to make sure that things got taken care of.
And if there was a problem, you know, and then our other friend who was very close to her was the more gentle, loving, you know, person. But if there was a problem, she knew I was going to handle it, and it made her feel at ease because I was
she can put her energies somewhere else.
Yeah. So it's nice having that personality blend. But at the end of the day, we're all there to help people and serve people.
Yeah.
You know? Yeah. So, and for me, I'm there to help people transition easily. You know, let's not make this such a big shit show. Yeah. You're there as the same way, you know, and to kind of have those kind of come to Jesus meetings with people and be like, look, this is what's actually really happening.
Yes, and I have no problem being that person that's up front and forward because, again, time is of the essence. Is that, like, we don't have time for me to sit here and hold your hand and be non-blunt about it. Right. This person is dying and we need a decision now. Yeah. And that's not being disrespectful in my mind. It is ensuring that we're doing what's best for the patient. Right. And I'm not here necessarily for you as a family member or someone that's with this person. I'm here for that patient. So I need you to help me help this person.
Right. You're the advocate.
Yes. Yeah. And so I tend to come off a little bit more blunt than most, but at the same time, I'm very efficient in the aspect of getting it taken care of. And, you know, like I said, someone else can come in and hold your hand. Right. But if I'm the only one there, like, it is within me. It's buried very deep.
We saw you cry. She does have a soul, everyone.
Buried very deep. But again, it's like there are patients that make it worth, Like, again, you feel fulfilled in the job that you're doing, and there are other patients that make you question why the hell you did this in the first place.
Right, yeah.
And so, and I'm not saying that anyone ever deserves to die, but there are moments that I'm like,
yeah.
Carry
on, peace out.
And patients need to take care of themselves. They need to help themselves before we can help them. And so when we get cases where it's been an obvious amount of neglect, health neglect, drug use, alcoholism, there's only so much that we can do. And I'm not judging anyone, but, work with me so that I can help you get to the best you. And sometimes that's hard for people to take on.
Right.
Yeah. And then their families are like, what do you mean? Like, this person's been an alcoholic for 40 years.
Right.
And again, not judging them,
they
but
put down a bottle of whiskey every day. That takes a toll on your body.
Their liver is completely shot, and there's nothing we can do about it. They're not a candidate for a liver transplant, unfortunately. It was just like, they're highlighter yellow, they're super jaundiced. I was like, they have ascites, they have all these other issues that, like, we can treat them, but it's going to be a Band-Aid on the Grand Canyon. Like, we cannot fix this.
That's a good analogy.
Yeah. Or the other one that somebody uses, it's a lifeboat on the Titanic. It doesn't necessarily keep the Titanic from crashing. It just maybe saves you for a little bit.
Yeah.
And then you got to deal with the freezing aspect, and maybe we don't let, Jack die. But that's a thing.
No room on that door for you. Yeah.
Exactly. But we say that stuff a lot, where it's like, again, however somebody's health is, and that's the other thing, is that people don't talk about their health, and they don't let family members or friends know really where they're at. I don't know if it's, like, again, an embarrassment thing. Some people may not be privy to it. Just recently talking to somebody that had no idea that their dad had some issues.
Right.
And I said, well, what's he taking these meds for? And they're like, I don't know, I didn't ask.
Right.
I was like, okay. I was like, and so when they come in and they realize they're sicker than they ever thought they were.
Right. That's a shock to people. Like, that's, again, why having these things in place, having these conversations, talking to your people. I know your mother-in-law's the same way. It was just like, head in the sand, nothing's happening, everything's great. Yeah. And you're like,
because I want to put a face on to keep my family happy. In the meantime, I'm dying.
Right. Yeah.
Or, drowning in these symptoms that, and we want to help. And that's the hard part, is that unfortunately, it will come down to a moment where we have no choice. And then they're all surprised, and you're like, well, this has been happening for the last 2 years,
Yeah. And you could have prepared people, and you could have eased them into it and had a plan and made it a more peaceful transition, but you have not.
Especially something like cancer. It's like, you can't necessarily hide that.
Right.
There are signs that people will pick up on, but, I'm just like, if you're in pain, like, let us help you. Let us do stuff for you. And it's just hard, and I worry for him, for my husband, when he has to deal with that.
Especially he's the only child, and it's very their close-knit family.
When we did our plans, we made sure that they did theirs. And I asked if he went with his folks to do that, and he said no. And I said, well, again, how do you know what their plans are? He goes, well, my dad does. And I said, okay. I was like, there's
only so much you can do and advocate for.
You can only provide so much help. I mean, we do the whole, like, you can lead a horse to water type of deal, but at the same time, I'm just like, I don't know. I just come from a very different family where, we explosively share our feelings. Right. It's not, some people would say we put the fun in dysfunctional, but it is on the table, and there's no question about how somebody's feeling. And even though you're going to have those moments that may lead to tears and words said that can be hurtful, there's no denying what the plan is.
Right.
So.
And there's no denying that we're all going to die. So get the plan in place and have a discussion with people. So there's, it isn't taboo, and it's not a surprise. And you guys are like, okay, we can handle this, and
it's still going to suck in the moment, but at least we're slightly prepared for it. I mean, our folks keep us up to date with appointments and things that they have going on, and there's no question about when this happened. I mean, I feel really bad for the nurses that are going to take care of my dad.
Bless them in advance for that one.
Yes, thank you.
Yeah. But even in my situation, like my friend's father, who has been a father to me my whole life, is getting to that point. And thankfully, he has been open about it. We all get text messages, and like what's going on and the prognosis, and they're religious based, so that's good. They have that understanding, and they've been putting those things in place. And we did their estate plan many years ago before there was any issue, and he had to end up going for open brain surgery. And I'm like, so me going to business mode, I'm like, okay, what's going on? What is funded? How's it? Like, let's look at everything, because he's the gatekeeper of all this information, and his wife is lesser knowledgeable about these things because he handled everything. And that happens a lot in family dynamics. And for me, stepping in, being like, okay, he has the blueprint for us. but there's the lack of execution.
Yeah.
So, oh my gosh, let's get you have surgery on Thursday, it's a Monday, oh my God, let's get this done right now. And I don't like that franticness.
Sure.
And we shouldn't have to have that franticness. Thankfully, they do have that wherewithal, and I am in the position I am, and they are more forthright about this and having those conversations. But it's difficult, and making sure that people do have that in place. So not only do you have your estate plan in place, and I hammer people on this, is that you have to physically transfer those assets. It is not enough to just do that estate plan. You have a nice paperweight and you've done step one, great, high five. Now the hard work comes in.
Yeah.
Please go to your bank. Please go to the recorders and get your deed placed in there. Get your investment brokers having the beneficiary as the trust and doing that final step to make it as easy for people as possible.
Yeah. Now, how often have you had to go to a hospital bedside to take care of stuff?
Quite often, yeah. And it's challenging for me in a lot of ways because I'll be asking questions about medical care, which I don't need to be, because they're not going to make it anyways.
Yeah.
So, yeah, that's an awkward conversation where I'm like, what if you have substantial physical limitations? What would you like to have done? And I'm like, it doesn't matter because you're literally hopefully going to be here on Monday where I can get this done before you pass.
Yeah.
That's hard. And, those are the hard ones where I'm with a laptop and a printer in a hospital room trying to get this done. Why they luckily have that wherewithal and the ability for me to do that. And as I leave, somebody codes, and I'm like, oh, I've got to shepherd you out. That's fine. I always bring...
You look at the staff, you're like, sorry, my bad, that was me.
Sorry, I always bring change when I go to the hospital. I got to pay the ferryman, and we go out.
We'll just put your picture up so that everybody knows you. Exactly. Like, oh, that's her. She's coming in. Who's she seeing?
Come. And it's like, I'm here. I'm like going to help shepherd you out, and it's interesting for me, and like it does take your toll, and especially like a recent one I have of a client, and he's an elderly man, elderly. He's elderly.
That's a word.
And his wife, who's also elderly, but she has very late stage dementia. He called me for an estate plan, and I'm talking to him on the phone, and I can hear her in the background. And if you have any kind of medical anything with anybody, and you can hear her, and I'm like, what's going on with your wife? Because he's like, Mary, I just needed you to give me 5 minutes, you know what I mean? And you can hear her, and you're like, she has zero capacity, zero. Yes. And sometimes they do have lucid days, and sometimes you can get them where they have the capacity, and they, it is like the Notebook, where you're like, oh, the story's about us. Oh my gosh. Yes, I know you. Oh my God, I've known you my whole life.
Yeah.
And then they dip out of it. This one was way past, and we had to end up getting a guardianship of his own wife. And that's rough.
Yeah, guardianships are one piece that are difficult for us. And it happens, not often, but it does happen. A lot of times they're with patients that maybe have like a mental disability or physical disability and no family to care for them. Yeah. So then they become the warden of the state, and they have a court appeal or court assigned legal guardian. They are very difficult to get a hold of in a very short amount of time. Yeah. So again, if we have a patient that's like not doing well, none of this is set up, and we treat everyone like they're a full code, well, they start to crash, or they need to go to surgery. We have to get consent for these things, and if the patient's not capable, whether or not it's a mental capacity because of an illness, or if that's their baseline of them having some sort of mental disability and can't speak for themselves, we have to contact this legal guardian. And
it's not in the business hours of Monday to Friday, 8 to 5. Good luck.
And healthcare, like we talked about holidays, healthcare doesn't take holidays. Yeah. We don't take, it's 24 hours a day. And so if they come in on a Friday night, I'm not getting a hold of somebody until Monday morning. Right. And so that piece has been difficult, I will say. And again, that's when we have two physicians that can kind of step in and decide this is emergency, life or death situation. We're going forward. And so they make the decision to either say, for example, take this patient to surgery, whether it's like a heart-related issue or something along those lines, or they say, we're not going to do anything because the likelihood that this patient's going to be at their baseline. That's kind of our goal, is to get somebody to leave the hospital the way you came in, or as close to it as possible. Yeah. And if we can't do that, there are other things we can do, like send you to a long-term care facility where you continue to rehabilitate and hope that you get better, trachea, and hopefully build those lungs up to where they can function on their own, get you off the ventilator, things like that. But yeah, legal guardians in particular are extremely difficult to get a hold of, and I don't know what their client list looks like. Do they cap out? I'm not entirely sure, but
I feel like there's like 2 people in the whole state who do it. You know what I mean? So I can't even imagine what their caseload looks like. You know, everyone's overworked, underpaid.
And so when we call them and they don't get back to us right away, and then we find out maybe later that's not what should have been done, or there wasn't paperwork that came with the patient or anything like that. And our case managers are nurses that have moved into that kind of administrative social work type of thing. And they can, I don't know how they're really good at Facebook stalking, I'm sure, because they can find next of kin like that. It blows my mind. I don't know what resources they use, but thank you. And so, but they can sometimes get a better hold of guardians than we can, and help us get in contact with people. But yeah, you find family members that don't want anything to do with them. They live on the opposite end of the world, and so they go through this legal guardian, and it's like, oh, okay.
Yeah, and that's why it's important to have those people in place, because if you don't have that, who's gonna be your person? Who's gonna call? Who are they gonna get a hold of? And it's a lot. I mean, it's a lot for people, and I don't think a lot of people understand the nuances of life and death, frankly, because there's a lot of paperwork. There's a lot of paperwork in dying, unfortunately.
Yep.
And it's nice to have that in place for people, and your people to have that in place for them to know your plan, your care, not the state's plan or the state's care,
I will say we've had, I think, maybe one time, kind of came back to bite us in the butt. I don't know if there was a legal piece that came out of this, but we resuscitated a patient that shouldn't have been resuscitated.
Yeah.
And again, we worked with the information that we had, because the patient came with no paperwork. EMS found nothing at the house that specified that the patient was a DNR, no pulse form, no nothing. So to us, if we don't have any of that, like, we're going to save your life and do what we can. Did resuscitation on this patient for probably about 45 minutes, which if you've done any extensive, physical activity for
sports,
longer than 2 minutes, it is exhausting on staff. We had to rotate multiple people in and out to do CPR. I think we completely exhausted every medication in our crash cart. I think we shocked the patient 2 or 3 times, trying to get our cath lab team up and running, so that it was this person who was dying from heart attack. And so we're trying to get their heart beating and keep them alive long enough to get cath lab up and running, so that they can go in and do whatever cath lab intervention they needed to do, stents or valve repair or anything like that. And so, again, that is extremely costly, I should say, in the aspect of meds, all the other
staffing,
everything that was given at that point. And so we had tubed the patient, and then by the time we got a hold of somebody that could tell us what was going on with this patient, because came in via REMSA, had nobody at the house with them, nobody listed anywhere for any contact information. Again, and a lot, having stuff within your home can help.
That's why we put it on the fridge.
We can't access this guy's phone to try and call people, and really neighbors couldn't give us anything. Said like, oh yeah, he's got a brother, you should talk to this person, like nothing. And so what do? We can't just let him die, right? So we resuscitated him, and then finally the next day, I think it was his sister had called and was beyond pissed that we had saved his life. And she goes, he wouldn't want that. He was a DNR. We're like, we found nothing anywhere. And she, you're telling us that now. And so then she was like, well, I'll come in and see him. We had done quite a bit of damage to this guy trying to save his life. And she was pissed. And she just blew up that she was going to sue us, that she was coming after the doctors who made the decision to push forward. And again, like you said, ultimately, like, our goal is to save your life, regardless of what you have. We've started compressions on someone, and in the meantime, someone had said, oh, this patient's a DNR. And then, or we look, and they have a pulse that specifies no chest compressions. Okay, so if we don't give chest compressions right now, but we put them on medications, we put them on a ventilator, does that still meet the needs? And can we keep this patient alive with just those interventions? We got to try it. Like, that's what's specified here. That's what we got to try and do. Well, in that case, back with the guy that was a DNR, but we resuscitated him. Yeah, his sister was like, "I'm suing everybody. And you guys don't know what you're doing." And it's just like, we tried, like, have smack our hand for trying to save someone's life. Like, fuck off.
Our bad.
Like I said, I don't know if it pushed into anything more legal beyond my need to know type of stuff. But it didn't go down super great because we had this guy where we had already charged him for all of these things. And again, you're going to get a bill for all the services that we did. And she was pissed and wanted the hospital to pay for that because we didn't do right by him. And I don't know where she pulled her paperwork out. Oh, that was a question I had for you. It was paperwork that was listed. It was a state, a trust in an estate and a power of attorney from another state. And obviously he didn't have it, but because she was the one that was listed for him. So she had a copy of it in like Texas, and he had nothing in his home that specified that. And so she brought it with her when she came to visit and was like throwing it in our faces. And we're like, how the fuck were we supposed to know that that's what was needed? Like we, again, thought we were doing right by the patient by resuscitating him. And so now she wanted somebody to pay for it. And I have, like I said, I have no idea.
And you guys will do that. You'll look like some of our clients will have like they'll put it in their wallets or whatever. You guys will look through that.
Oh yeah. We go through all of that. And again, like I said, our case management team can track stuff down. Yeah. I don't know how, but they do, to say, oh yeah, this person had one drawn up in the state of Texas and his sister is his next of kin and we have a number for her. And I'm like, I don't know how you guys found that in 45 minutes in the entire time that we've been doing all this or whatever. And so, but anyways, it can sometimes come to bite you in the butt, but at the end of the day, I think most people would be
thankful that you saved their loved one.
Tried, you know, even if it doesn't work, or we say, hey, we tried to resuscitate this person, whether or not they were a DNR, and we didn't know that, but they also didn't make it.
Well, that's what I try to tell people. I'm like, the hospital's default is to always keep people alive. That's just your oath. That's what you guys are supposed to do. And we have a mutual friend who is an ER doc, and they were doing that. They coded, and they were doing chest compressions, and the wife is literally just sitting there watching. And finally, a Care Bear nurse came by and said, ma'am, you know, this is probably not what you want to watch. And she goes, what are you doing? He didn't want that.
Speak up.
And that's what she was, you know, watching your loved one dying, and you go into that shock and that grief all of a sudden, and then watching that, you know, it's traumatic. And like, I think she just was like, I don't know what to do here. And luckily a nurse was like, ma'am, and she was just like, yeah, no, he didn't want any of this. What are you doing? Yeah. And then they're like, oh. Hey, everyone.
Yeah.
And just kidding.
And then on the flip side of that is someone saying, do everything. And then they start watching you do it. And they're like, oh my God, stop. Like, this is too much. I can't sit here and watch you do this to him anymore. And so things can change.
Because it's not like the movies and the shows. It is horrific to watch it.
It is.
Like, and I've had, like I said, when I go to the hospital and someone codes and they're doing that, and then nurses so nicely are like, we're so sorry. And I'm like, all my friends are in medical. Like, this is normal. Do I need to stay here for 10 more minutes while they code completely, where I walk them out? Like, you know, what do you need? You know, and she's like, oh, okay. You know, I'm like, it's a very natural process. It's just, it is what it is and what you guys deal with. But it's not pretty. Yeah. It's literally not what you see in the movies.
And ultimately, if we get a patient that wants to go home to pass, right? We do everything that we can do to try and get them as stable as we can to get them home and carry out whatever, you know, wishes they have. If it's they want to die in their garden looking at whatever.
That'd be amazing.
And we work with hospice. We work with a lot of other agencies that help meet those needs. But we get that a lot where patients are like, they don't want to die in a hospital.
No, nobody wants to die in a hospital.
I'm like, yeah, no. I was like, other than the convenience of having someone like me handle everything after the fact. We have had somebody that said, they're like, I don't want this person to die at home because then they're going to haunt me. I've heard that before. And so they're just like, can they stay here? You know, that sort of thing. And there are moments that patients are too unstable to get home. And unfortunately, they have no choice but to die here. And so that's when we're like, bring in things from their home, bring in their family, bring in, you know, I won't say no to animals. That sort of thing. We're typically not supposed to, but, you know, I'm just like, if that's what's important to this patient right before they die, let them do whatever the hell they want.
Well, you've seen the one hospital where they let the woman's horse come in.
Yes,
which is super cool. Yeah, so they let, you know, like the woman's horse come in because that was, you know, her whole life. She was equestrian and, you know, like people's dogs and stuff. And it's like, these animals are important to them, especially if you don't have anybody else,
when
you know?
that's your companion, you know?
You're so needed. Yes, you are. So needy right now.
She's like, when are you going to die? Just kidding.
Well, like, they will. If I did die here, they would eat my eyeballs because that's the sweetmeats, and that goes first, you know. Because, like, bitch isn't feeding them after 10 minutes, and their bowl is empty, you know.
So they're starving.
Eyeballs.
They're wasting away.
They are. Clearly, this one's wasting away. Fat ass. Gosh, she's so chonky.
Chonkers.
Yeah, it's super interesting. Like, I don't know, like people don't understand, and it's nice to have these conversations where people actually have kind of now a working knowledge and like what to expect and like the unknown. I think the unknown is what's most scary for people.
Yeah. It's always one of those, and I know obviously HIPAA is the biggest violation of all in the aspect of like, you know, I want you to come to work with me for a day, you know, one, just to see exactly what we do. I remember when there were the conversations from the gals at, I can't even remember who said it now, that said that nurses sit at the nurses station and play cards all the time. Was that during COVID?
Yeah.
That like nurses don't do anything.
Right.
Why is she wearing
hilarious.
a doctor's stethoscope, things like that. And so just one, to see what we have, like what we have to deal with on a daily basis. But two, to also, like you said, you're like, we don't know what the dying process looks like. Like sometimes it's just almost easier to show you than it is to try and explain it. Yeah. And I think that if people got exposed to that more often, as morbid as that sounds, I mean, we can't do like what was the... Mike Rowe did Dirty Jobs.
Oh, right,
you know,
yeah.
Like you could do something like that without, you know, breaking HIPAA violations or having patients sign on to it and stuff. And, you know, we've had some patients, even when we have like nursing students, where I'm like, this is a student, do you mind if they come in and talk to you? And most patients are pretty good with stuff like that. But some of them are like, no, I don't want this person in here, which we, again, have to respect that. But yeah, I'm like, sometimes it's just easier to be able to do that. And I think
and that's what happens with me, is that people don't come to me to get this done until they've actually physically experienced it with their loved one. Yeah. And then they're like, oh shit, this is awful.
Yeah. And they're like, and this makes so much sense to do this and do it now and you know, just get it done. I don't know, as far as I don't know, people have talked about prices of stuff, like to get this done. It was a little bit more expensive than I expected it to be, but it's definitely like having that done and in place can save you expenses on this end.
Oh, wait, you save your family so much money. You know, it's a $2 billion industry a year, $2 billion with a B.
Jeez.
And 90% of that goes to attorney's fees for going through probate, because they take a percentage of your entire estate.
Jeez.
Which is, to me, criminal in a lot of ways. Like, I'm going to take a percentage of someone's life. Like, that doesn't sit well with me. Where you can do a little pre-planning for your loved ones to save them on the back end for that grief, that time, that expense. And then from somebody, you know, with their mahogany desk and their Maserati, you're making a payment for them.
Yes.
Because you failed to just put a little bit of upfront cost to get it done. And again, we have the tiering to make it as affordable as possible. I mean, you can get this done for $250 because I make it that accessible for you to get this done for people who can't afford it, to do it yourself. Yeah. They can do it themselves, you know what I mean? And obviously if they need me to help them through it or whatever, I'm happy to do that. But there's literally no excuse for you not to get this done for your loved ones. Like, we make it ultra affordable, you know, because I want everybody to have access to this. I don't want to be people being precluded from financial or socioeconomic reasons to not have access to justice, access to legal forms.
And especially as patients age, you know, and they're like, oh, it's one more expense I have to take care of. And it's just like, well, should have done it before. I don't know. It does. It always blows my mind, the number of people that like don't know anything when I ask those questions on admission, like, do you have a power of attorney? And they're like, what?
What's
like,
that?
Never heard of it. Do you have a will or a trust?
Medical directive,
Nothing,
living will,
anything. Yeah. And they're like, no. And one of the things that we have to check on our paperwork is, do you want someone to come and talk to you about it? Yeah. And so when we click yes or no, it automatically triggers to our social workers that they need to come and assess this patient and talk to them about what they need, like what their needs are. I think knowing what resources you have in the community is another huge piece, like yourself, as far as like I've seen some of your stuff on TikTok, and obviously I know you from soccer and stuff like that, and I know that's where you and I send people to you or you say, hey, like you need to get this taken care of, go see Lindsay. But I think people maybe not knowing what that is, or just worried about how much it costs, things like that, I think is a huge barrier to a lot of people getting this taken care of.
Well, and a lot of people think like, oh, this is for rich, affluent people. That's a trust. That's what rich people have. And it's like, no, for my demographic, it's, I'm just getting your family to avoid probate. I'm getting your documents in order for your medical professionals and making sure that it is as easy as possible for you to transition whenever you feel like you're going to do that. You know what I mean? Like, I always say, whenever you decide to pass away, great, you know, that's already in place for you, and you've got that done, and you don't have to worry about it after that, you know, like, just get it done, you know, and then And then it's not set in stone too. Like every 3 to 5 years, take a look at it. You know, like that's what's important is it's not set in stone. So I think people get that kind of paralysis of like I have to make this hard and fast decision for the rest of my life, and that's not true.
And it's going to stand this entire time. Like I said, I mean, this pulse form can change in a matter of minutes.
Right. Yeah.
And I've seen it change 3 or 4 times in a set of 50 minutes.
Right.
Just because patient declines, they respond to medication, they're like, oh, he's doing fine, okay, let's go back to being a full code, and then they start to decline. And it's just like, it's this back and forth shit, and sometimes I'm like, okay, like make a decision.
Right, yeah.
But at the same time, it's their right to make changes.
As long as they're aware and cognizant and can communicate to you guys.
Yeah.
So for you guys, what is important, like can you guys, for that one patient who was a do not resuscitate and you're doing all the things and then all of a sudden, lo and behold, they're not, can you guys look at like prior doctor notes, and if they went to their primary and they have it on file, you guys can access that, right? You guys all kind of talk to each other.
Yeah, if it's within our system, and most often patients come to a specific hospital because it's within their insurance or they're associated with their primary doc and things like that. And so we can look back like, oh, this person was in the ER 2 days ago for the same thing. And this is what this doctor recommended. And like, the patient left against medical advice, and now they're here, now they're here having a bigger issue, and we're having now this conversation of end of life. And so was it that they changed it then in the ER? Like, and these are dated, these pulse forms are dated and time-stamped and all the things. And so,
and the power of attorneys are notarized and dated.
And so we can see when changes come up. And so we can compare back through notes. We can compare back through how were they presenting, what did their lab work look like then, all of those things versus now. So we do a lot of comparison to say like this patient has been actively declining over the last 6 months. They've been in and out of the hospital in the last 6 months multiple times. Has it been for the same thing? Yes. Like,
does their primary have their power of attorney on file,
yes,
and then you guys can pull that?
Yes, and typically I think that's where our case management team kind of starts, is they reach out to the primaries, which again I will hopefully be able to one, push that through as I become a nurse practitioner, and then be able to help
advocate for that for them. Yeah, that's important, because I always tell my clients, I'm like, they're like, well, what do I bring to my doctor? And I'm like, bring section 5, which is our medical section, bring all of that to them. They love it. If they have something in place, sometimes they'll have facilities will have their own that they like to have, because they have certain questions that their lawyers have wanted them to put in place to basically CYA themselves. But I go, if you give your medical professionals any guidance, they are happy people.
Yeah.
They know.
And I know that in the primary care offices, they take copies of those and keep them as in their records and things like that should they go somewhere else. And we ask patients to update us if things change, and especially with conditions that are chronic. And if we are trending those conditions and we start to see more and more of a decline and things like that. So, so it's something that's seen on both ends. And the same thing, like if someone were to bring it in just for an acute visit, we scan those items in, and so that it's kept on file somewhere.
Right. Yeah. So somebody has access to it. Thank you for listening to this podcast. If you found value, please like, subscribe, and share. And be sure to follow me on all the socials at Sips and Tips with Lindsay. And of course, you can always go to my website, sipsandtipswithlindsay.com, to find more information about estate planning, business, snowboard, travel, and of course, wine. As always, we have to get the legal stuff out of the way. I went to law school, so you don't have to. However, we have to read the special disclaimer that I am not a practicing attorney. I am not your attorney. I am not offering any legal advice in any content or any episode. All content is for your information and educational purposes only. It is not a substitute for seeking your own legal advice from your own attorney or other professionals such as a CPA or financial advisor. I cannot give legal advice and do not offer any legal services or legal advice, but I do offer some fun and educational content for you to enjoy.